Honored to introduce our dear friend, Professor Dr. Nagy Saghir from Lebanon, in ABC guidelines in metastatic breast cancer. Professor Nagy.
Good afternoon. Thank you, my friends, and I thank the committee for asking me to give this presentation. But after Dr. Hussein Khalid, and he passed on 140 messages plus a review of the manuscript. So I don't know how much we can still talk. I'm to give you an overview of the advanced breast cancer guidelines. In the program, it says for metastatic. Actually, I had prepared a review of the ABC2, which are not yet finished. So I will be mixing both of them. I may need to go over time, but please stop me when the time is over. Same as in St. Gallen, this is a copy, and on Saturday morning at the Advanced Breast Cancer Conference was the consensus panel with the questions prepared before and voted on in front of the audience. This was already published in the breast in 2012, and most of you have seen it. The Advanced Breast Cancer ABC2 was held 2 months ago in Portugal, and the guidelines are not yet published. We are still fine-tuning them, and you can see that in the text I have underlined some writings. This was not done by the panel. I just did that for the purpose of clarity. So we'll still have to wait a couple of weeks probably to get the final slides out, and the publication soon, maybe within 2 months. This was the Saturday morning session. Now, as a reminder, guidelines really are based on the best available evidence, which is the most powerful, usually obtained from randomized clinical trials, and clinical practice expertise, which is less powerful when we do not have a clinical trial. It's important to grade the guidelines. It's the strength of the evidence, and also comes the strength of the recommendations. At ABC2, this is the grading system that we used, and briefly I wrote down on the slide that the level 1 is really when we have strong recommendation, level 2 weak recommendation, and the latter is the quality of the evidence. We look at the benefits versus side effects and risks. It's high quality of evidence when it's A, moderate is B, and C is poor quality of evidence. All members were asked to vote on all questions. Sorry. Okay, the general recommendations. One is that multi and interdisciplinary teams are very important, crucial. We give more attention usually to adjuvant treatment. St. Gallen has been on for more than 14 years for adjuvant, but for metastatic, this process has just started. There have been studies that showed that patients with metastatic breast cancer do not get much attention as the early breast cancer. We know that, you know that. In your tumor boards, you usually present the early cases and rarely present the metastatic. Thank you. Supportive care. The new definitions of supportive care is that really has to be started from day one. Supportive care really has to be started from day one. Metastatic breast cancer is incurable. It has to be, the panel agreed that really this has to be clear when we discuss it with the patient. In our culture, it may be difficult to give all the information out. Many of us, most of us, what we do, gradually we give the information out, but people have to know and what they are at. The minimal staging workup for metastatic breast cancer includes history and physical exam, complete labs, imaging of the chest, abdomen, and bone. Brain imaging is not recommended routinely. That the panel agreed on that. The clinical value of tumor markers, that they are good really for follow-up if they are elevated to indicate the response of the treatment. The panel agreed that the tumor markers alone should not be used to decide on the treatment for decision making. Biopsy of the metastatic lesion should be performed if easily accessible to confirm the diagnosis, particularly if it is the first time patient is being diagnosed with metastatic disease. Biological markers, receptors, should be reassessed at least once if clinically appropriate. And if the results of the tumor biology and the metastatic lesion are different from the primary, here there are still controversies, but that the panel, the expert opinion agreement was that the use of targeted therapy to be considered when receptors are positive at least in one biopsy. So the change of treatment is still being debated. I'll talk about this a little later also. But that if the patient becomes HER2 positive or if the lesion becomes receptor positive, then the patient can be considered for targeted therapy, whether hormonal or anti-HER2. The choice of therapy, that is known to most of you. Really, we rely on the hormones, HER2 status, prior therapies, tumor burden, comorbidities, rapid growth of disease, socioeconomic and psychological factors are usually taken into consideration. Now, the age of the patient, the panel agreed that the age should not be a reason to withhold effective therapy. A small but very important subset of metastatic breast cancer patients, like those with oligometastatic disease, with minimal disease, can achieve a complete response and a long-term survival. So those should be always targeted and managed by multidisciplinary management. Now, as for the removal of the primary, this remains always controversial. You might be addressing this in a different session. But the panel agreed in 2011, published in 2012, that surgery is valuable if performed optimally in a patient who is responding to treatment. And if it is done properly, it should be complete. Now, waiting for clinical trials, we did talk about this at ABC2 last month, and then after the meeting, we have the two trials that were presented at San Antonio. They were negative, but there is still a lot of debate about them. So this issue remains under discussion, but the most acceptable expert opinion is that if a patient is responding to treatment and has disease, that the surgery for the breast may be considered only under such conditions. Specialized oncology nurses at ABC2 was addressed, recommended, very important, they should be part of the multidisciplinary team. In some countries, physician assistants or specially trained practitioners are also act at the same function. At ABC2 was discussed again, the age should not be the sole reason to withhold effective therapy, nor to over-treat. And the age should not be used to determine the intensity of the treatment by the almost like 100% of the votes. Now, at ABC1, we had agreed on that endocrine therapy in a patient who is HER2 who is ER, hormone receptor positive, even in the presence of visceral disease, endocrine therapy remains the preferred option, unless there is concern that there is endocrine resistance or there is a rapidly progressive disease that needs a fast response. For premenopausal women, ovarian suppression or ablation combined with additional endocrine therapy is the first choice. Oophorectomy or LHRH analog, depending how much money you have, how much your government or insurance allows you. But very often we do oophorectomy when we can. Some people do LHRH analog every month. Both are acceptable. Additional hormonal therapy usually is tamoxifen. So ovarian suppression ablation with tamoxifen. Aromatase inhibitor is agreed upon as a viable option, provided that you make sure that the ovaries are suppressed or ablated. Now, the preferred first-line therapy for endocrine therapy postmenopausal women is an aromatase inhibitor with tamoxifen, viable option in selected patients and also countries. The optimal post-aromatase inhibitor treatment remains uncertain. We did discuss this later on at ABC2. I will go over this. Now, chemotherapy in patients with metastatic breast cancer, both combination and sequential are reasonable. However, the panel recommends sequential monotherapy as the preferred option for metastatic breast cancer. Combination chemotherapy should be reserved to patients with rapid clinical progression, life-threatening visceral metastasis, or need for rapid symptom and or disease control. And I will talk later on what we call visceral metastasis and visceral crisis in the at ABC2. The duration of each regimen of treatment and the number of regimens should be really tailored to each individual patient. The regimen usually given until progression of disease or unacceptable toxicity. And the unacceptable toxicity really should be assessed by with the patient, not just the perception of the doctor, but also what the patient perceives. Stereotactic radiosurgery or surgery for metastatic breast cancer with brain metastasis, both are viable options. If there are small number of metastasis, stereotactic radiosurgery is as good, and we did discuss this at ABC2, that it is less toxic if it's feasible than SRS is a very good option. When surgery is performed, it may be followed by whole brain radiation therapy, and whole brain RT should be offered to patients to whom SRS or surgery are not appropriate. Now, what is the preferred first-line endocrine therapy for postmenopausal patients? Aromatase inhibitor or tamoxifen. That is important depending on what the patient did receive also in the adjuvant setting. Fulvestrant was considered as an alternative option. Aromatase inhibitors plus everolimus is also an option after progression on a non-steroidal aromatase inhibitor. Now, at ABC2, this issue was discussed again. We had the data from the Bolore-2, we have the data from the Tamrad, and everolimus 2 added to NAI is a valid option. The discussion ongoing whether we should specify everolimus plus steroidal aromatase inhibitor exemestane after failure of anastrozole, after progression on anastrozole or letrozole. And we agreed that probably we will include in the manuscript the referral to using tamoxifen plus everolimus as per the Tamrad trial. Now, for HER2 positive disease, first-line setting, we discussed it at ABC2. Previously, HER2 positive metastatic breast cancer previously treated or untreated, yani treated in the adjuvant setting or untreated, the first line chemotherapy plus trastuzumab are superior to chemotherapy plus lapatinib in terms of progression-free survival and overall survival. This takes into consideration the effectiveness and the tolerability of trastuzumab, which is much better than lapatinib, and the non-tolerability of lapatinib has a role in the fact that doses may be reduced. In first-line therapy, HER2 positive metastatic breast cancer, combination chemotherapy plus trastuzumab plus pertuzumab is superior to chemotherapy plus trastuzumab. We have here level 1 also evidence, the Cleopatra trial that was published. This is the preferred treatment option. Now, how does it compare to other anti-HER2 such as TDM1? We do not know yet, but the majority voted yes on that. Now, as for HER2 positive metastatic breast cancer beyond first line, there are no data supporting the use of dual blockade with trastuzumab and pertuzumab beyond the first line, after treatment with pertuzumab first line also. So therefore, it should not be done outside of clinical trial beyond progression. Now, in a HER2 positive metastatic breast patient, previously untreated with pertuzumab, it is acceptable, and this is an expert opinion, to use pertuzumab beyond first line, not just upfront. Also, patient was not treated with pertuzumab. It is acceptable to use it. However, we have to say that this is not supported by clinical trial. This is just expert opinion. Now, after first line trastuzumab-based therapy, TDM1, which is trastuzumab with Imtensin, provides superior efficacy. You all know that from the Emilia trial, relative to other HER2-based therapies. TDM1 should be preferred in patients who have progressed through at least one line of trastuzumab-based therapy, as it provides overall survival benefit. Now, all patients who relapse after adjuvant anti-HER2 should be considered for further anti-HER2 therapy unless there is a counterindication. The choice of anti-HER2 depending on the availability, the specific anti-HER2 that was administered, and the relapse-free survival. The optimal sequence of all available anti-HER2 therapy remains yet unknown. Now, because in terms of brain metastasis, we just added this on at ABC2 as compared to ABC1, is that because patients with HER2 positive metastatic breast cancer and brain mets, we have those patients that survive for several years. Consideration of long-term toxicity is important, so the less toxic treatment, such as stereotactic radiotherapy, should be preferred when available, and the majority agreed on that one. Now, in HER2 negative metastatic breast cancer, patients pre-treated in the adjuvant or metastatic setting, if they were treated with anthracycline and taxane, or who do not need combination chemotherapy now, it is acceptable to use single agent like capecitabine, vinorelbine, or eribulin. They are preferred choices. Additional choices would include gemcitabine, platinum, or taxane, or liposomal anthracyclines. The decision should be individualized, really take into account the toxicity profile, previous exposure, and patient preferences. Now, in patients with BRCA-associated triple-negative or endocrine-resistant metastatic breast cancer, pre-treated with anthracycline and taxane, the panel agreed that treatment with a platinum regimen may be considered outside of clinical trial. Otherwise, all other recommendations similar to sporadic metastatic breast cancer. In terms of liver metastasis, this was discussed extensively, and there is no data regarding the effect on survival. Like patients should be informed of that, and when we discuss local therapy, and it can only be proposed to very select cases of good performance status with limited liver involvement. Okay? That's it? Or you want to hear a little more? All right.
2 minutes, Professor Nagy.
But then where I was.
Finished?
Allah, thank you. Just to finish this.
Scroll the slides.
Yalla. We're almost done. Okay. Okay. 2 minutes are gone, no? Malignant pleural effusions, you know how to manage those. Metastatic male breast cancer, we recommended earlier on, the panel recommended that endocrine, for ER positive, endocrine therapy is the preferred option unless there is concern, proof of resistance or rapidly progressive disease that needs some fast response. Tamoxifen is the preferred option for those who need to receive an aromatase inhibitor, concomitant LHRH agonist, or orchiectomy is necessary. That was 3 years ago. Now at ABC2, the panel agreed that concomitant LHRH analog or orchiectomy is the preferred option, but AI monotherapy may be considered and with close monitoring of response. And we do need clinical trials in this patient population. Now, the other really thing concerning locally advanced breast cancer, I guess we do not have time to discuss that. And Dr. Ghazali already spoke about the BGICC. We have a lot of additions, but thank you very much for your attention.
Thank you very much, Professor Nagy. Professor Saeed, no questions? No questions.